Pharmaceutical treatments for Parkinson's disease, a report for patients over 70 in New Zealand. Report date, the 18th of January 2026. Executive summary. This report provides a detailed analysis of pharmaceutical treatments for Parkinson's disease, PD, with a specific focus on their suitability for patients over the age of 70 in New Zealand. The primary objective is to balance the management of motor symptoms, such as tremor and impaired mobility, with the critical need to preserve cognitive function. Levodopa remains the most effective and potent treatment for the motor symptoms of PD and is the recommended first-line therapy in New Zealand for this age group. While it significantly improves mobility and quality of life, it can cause cognitive side effects like confusion and hallucinations, particularly in older adults. Careful dose management is essential. Dopamine agonists are generally not recommended as an initial treatment for patients over 70. They are less effective for motor control than levodopa and carry a significantly higher risk of severe neuropsychiatric side effects, including impulse control disorders, psychosis, and excessive daytime sleepiness. MAO-B and COMT inhibitors serve as valuable adjunctive therapies to levodopa. They help extend the effectiveness of levodopa doses and manage motor fluctuations. Their cognitive safety profile is generally more favorable than that of dopamine agonists, although MAO-B inhibitors can still cause confusion in some older individuals. Anticholinergic medications are strongly discouraged for elderly patients. While they can help with tremor, they pose a substantial risk of causing significant cognitive impairment, including confusion, memory loss, and an increased risk of dementia. Emerging therapies are in development globally, aiming for improved efficacy with fewer side effects, but are not yet approved or available in New Zealand. The cornerstone of management for an older patient with Parkinson's in New Zealand is a carefully tailored regimen, led by a specialist, that prioritizes levodopa for motor control while vigilantly monitoring for and managing any adverse cognitive effects. Introduction. Parkinson's disease is a progressive neurodegenerative disorder resulting from the loss of dopamine-producing cells in the brain. This dopamine deficiency leads to the characteristic motor symptoms of tremor, rigidity, slowness of movement, bradykinesia, and postural instability. In addition to motor challenges, non-motor symptoms are common and can be highly impactful, particularly cognitive impairment, which can range from mild difficulties to dementia. For patients over 70, managing Parkinson's disease presents a unique challenge, finding the optimal balance between controlling debilitating motor symptoms and preserving cognitive health. Medications that improve mobility can sometimes negatively affect cognition and vice versa. This report synthesizes current research to evaluate the primary classes of Parkinson's medications available in New Zealand, assessing their effectiveness, cognitive impact, and overall suitability for the older adult population. Levodopa formulations. Levodopa is the most effective medication for treating the motor symptoms of Parkinson's disease. It is a precursor to dopamine that can cross the blood-brain barrier, where it is converted into dopamine to replenish the brain's depleted supply. Effectiveness for tremor and mobility. Levodopa is considered the gold standard for improving motor function. It is highly effective at reducing bradykinesia, slowness and rigidity, stiffness, and often helps with tremor, swallowing, and drooling. In New Zealand, a combination of levodopa with a decarboxylase inhibitor, either Carbidopa or Medsafe, is the recommended first-line pharmacological treatment for patients over 40 who experience functional disability from their symptoms. This combination prevents levodopa from being converted to dopamine in the bloodstream, which reduces side effects like nausea and ensures more of the medication reaches the brain. Cognitive profile. The cognitive effects of levodopa in older adults are complex. Adverse effects. Levodopa can cause central nervous system side effects, which may be more pronounced in patients over 70. These include confusion, hallucinations, delusions, psychosis, and agitation. Potential benefits. Despite these risks, some research suggests that appropriately managed levodopa therapy may not accelerate cognitive decline and could even have a protective effect. One study noted that cognitive function remained stable in patients who received increased levodopa doses. Formulation impact. There is currently no strong evidence to suggest that different oral formulations of levodopa, for example, immediate release versus controlled release, have a different impact on the rate of cognitive decline. Suitability and safety for patients over 70. Due to its unparalleled effectiveness for motor symptoms, levodopa is the cornerstone of therapy for most older patients. Its use has been shown to dramatically improve functionality and quality of life. However, because of the heightened risk of cognitive side effects, the standard clinical approach is to start low and go slow, initiating treatment with a small dose and gradually increasing it to find the lowest effective amount. Regular monitoring by a physician is crucial to watch for the emergence of hallucinations or significant confusion. Availability in New Zealand. Levodopa formulations are widely available and funded in New Zealand. Common brands include Levodopa/Carbidopa, SINEMET, SINEMET Sour, Levodopa/Benzocyde, Medsafe, Medsafe HBS, Medsafe Rapid, Levodopa/Carbidopa/Entacapone, Stalevo, a combination pill that includes a COMT inhibitor dopamine agonist, DAs. Dopamine agonists are medications that mimic the action of dopamine in the brain by directly stimulating dopamine receptors. Effectiveness for tremor and mobility. DAs can improve motor symptoms and may be used alone in the early stages of PD or in combination with levodopa in later stages. However, they are generally considered to provide less potent motor benefit than levodopa. Cognitive profile. Dopamine agonists are associated with a high risk of significant neuropsychiatric side effects, particularly in older adults. Impulse control disorders, ICDs. DAs carry a well-documented risk of causing ICDs, which are characterized by an inability to resist harmful urges. This can manifest as pathological gambling, compulsive shopping, hypersexuality, or binge eating. Psychosis and hallucinations. The risk of hallucinations and psychosis is notably higher with DAs compared to levodopa, especially in patients with pre-existing cognitive vulnerability. Excessive daytime somnolence. DAs are known to cause profound drowsiness and sleep attacks, where a person falls asleep suddenly and without warning. This poses serious safety risks, especially when driving or operating machinery. Suitability and safety for patients over 70. Dopamine agonists are generally not recommended as a first-line treatment for patients over 70. The American Academy of Neurology guidelines specifically advise against their use in this age group, as well as in patients with pre-existing cognitive impairment or a history of ICDs, due to the high risk of adverse effects. If considered at all, it must be with extreme caution and close monitoring. Availability in New Zealand. Several dopamine agonists are available and funded in New Zealand, including ropinirole, ropinpramipexole, ramipex apomorphine, Movappo, an injectable form used for advanced PD. MAO-B inhibitors. Monoamine oxidase B, MAO-B, inhibitors work by blocking the action of an enzyme in the brain that breaks down dopamine. This increases the amount of available dopamine. Effectiveness for tremor and mobility. MAO-B inhibitors provide a modest benefit for motor symptoms, including slowness, stiffness, and tremor. They can be used as an initial monotherapy for mild symptoms to delay the need for levodopa, or more commonly as an add-on therapy to levodopa to help reduce off-time periods when medication is not working well. Cognitive profile. The cognitive effects of MAO-B inhibitors are varied. Some studies suggest rasagiline may offer mild cognitive improvements, but overall, their effect on cognition is not consistently superior to a placebo. They have shown some benefit for non-motor symptoms like fatigue and sleep disturbances. While generally better tolerated than dopamine agonists, they can still cause confusion and hallucinations in older adults. Suitability and safety for patients over 70. MAO-B inhibitors are a reasonable adjunctive treatment option for older patients on levodopa who are experiencing motor fluctuations. They are generally well tolerated, but caution is still required due to the potential for confusion. Availability in New Zealand. Rasagiline, Azilect, is funded in New Zealand and is a common choice. Selegiline may also be available, though it has faced supply issues and may require special approval. COMT inhibitors, catecholomethyltransferase (COMT) inhibitors are medications that are taken with levodopa. They block an enzyme that breaks down levodopa in the body, allowing more of it to reach the brain and extending its duration of action. Effectiveness for tremor and mobility. COMT inhibitors have no direct effect on Parkinson's symptoms on their own. Their sole purpose is to enhance and prolong the effect of levodopa. They are used exclusively as an adjunctive therapy to help manage wearing-off phenomena, where the benefit of a levodopa dose diminishes before the next dose is due. Cognitive profile. The cognitive profile of COMT inhibitors is directly tied to their effect on levodopa. By increasing levodopa levels, they can also amplify its potential cognitive side effects, such as confusion, hallucinations, and dyskinesia, involuntary movements. Suitability and safety for patients over 70. For an older patient experiencing predictable wearing-off periods with their levodopa regimen, adding a COMT inhibitor can be an effective strategy to smooth out their motor control. The decision to use a COMT inhibitor must be weighed against the risk of exacerbating levodopa-related side effects. Availability in New Zealand. COMT inhibitors are available and funded in New Zealand. Entacapone, Countantolcapone, Tasmara combination tablet, Stalevo, which contains levodopa, Carbidopa, and entacapone, is also funded. Anticholinergics. Anticholinergic drugs work by blocking acetylcholine, a neurotransmitter that becomes relatively overactive when dopamine levels fall. Effectiveness for tremor and mobility. These medications are primarily used to help control tremor and are sometimes used for dystonia, sustained muscle contractions. Their effectiveness for other motor symptoms is limited. Cognitive profile. Anticholinergics pose a very high risk of adverse cognitive effects. They are well known to cause cognitive slowing and confusion, hallucinations, severe impairment of short-term memory, increased risk of dementia with long-term or cumulative use. Suitability and safety for patients over 70. Anticholinergic medications are generally avoided and not recommended for patients over 70. The significant risk of inducing or worsening cognitive impairment and delirium far outweighs their modest benefits for tremor in this population. They are more commonly reserved for younger patients with tremor-dominant PD. Availability in New Zealand. Antimuscarinic medicines like benztropine and procyclidine are available but are generally not used for Parkinson's disease in older patients due to their poor side effect profile. Newer and emerging medications. Research continues to advance, with new therapies on the horizon that aim to provide better symptom control with improved cognitive safety. Amantadine, Simetrol, this older medication, available in New Zealand, acts as a weak dopamine agonist. It can help with tremor and stiffness but is most often used to reduce levodopa-induced dyskinesias. It can also have cognitive side effects. Tavapadin, a next-generation dopamine agonist currently in late-stage clinical trials overseas. It targets different dopamine receptors, D1/D5, than existing DAs, which may result in a better side effect profile with less risk of sleepiness and psychosis. It is not yet available in New Zealand. Stem cell therapies, for example, Vimdana-Procel. These experimental treatments aim to replace the dopamine-producing cells lost to the disease. While promising, they are still in clinical trials to validate their long-term safety and efficacy, including their cognitive impact. They are not available in New Zealand. Conclusion and recommendations. For a patient over 70 with Parkinson's disease in New Zealand, the primary goal of pharmaceutical treatment is to maintain functional independence and quality of life by controlling motor symptoms without compromising cognitive function. Levodopa is the cornerstone. Levodopa combined with carbidopa or benzocaine is the most effective treatment for motor symptoms and should be the first-line therapy. Treatment should be initiated and adjusted carefully by a specialist to find the optimal dose that maximizes motor benefits while minimizing side effects like confusion or hallucinations. Avoid high-risk medications. Anticholinergics should be avoided entirely. Dopamine agonists should also be avoided as an initial therapy due to their high risk of causing impulse control disorders, hallucinations, and somnolence. Use adjuncts strategically as the disease progresses. MAO-B inhibitors, for example, rasagiline, and COMT inhibitors, for example, entacapone, are valuable tools to add to a levodopa regimen. They can help manage motor fluctuations and extend on time, with a more favorable cognitive safety profile than dopamine agonists. Prioritize comprehensive monitoring. Management must involve regular follow-up with a healthcare provider to monitor not only motor symptoms but also non-motor symptoms, including cognition, mood, and sleep. Open communication about any new or worsening symptoms, especially confusion, memory issues, or unusual urges, is critical for safe and effective treatment. By following a carefully considered, individualized treatment plan, it is possible to effectively manage the motor symptoms of Parkinson's disease while actively protecting the cognitive health of the older patient.